a decade of learning and progress. Back in 2011, I was fortunate enough to attend a conference that started to introduce the concept of ICG imaging. A year later, things were moving fast, and in 2013, Professor Belgrado presented on FGMLD, fluoroscopy-guided manual lymphatic drainage, and fill and flush at several conferences. In 2014, following training, the Lymphoedema Training Academy changed its MLD technique to reflect this new knowledge and commenced fluoroscopy-guided training in October 2014. When your eyes are opened, they cannot go back. But in reality, as Professor Belgrado says, we're still at the stage in this technology of still only having one eye open. We have so much more to learn, and technology is advancing to allow us to see more better. I knew that I needed to bring this technology to patients, and I bought my photodynamic eye camera in 2014 and set up LymphVision. It's not been an easy journey, as many of you know, but it has been worth it. It has changed and continues to change the lives of many. ICG imaging has changed everything forever. For the first time, we could see lymphatics moving in real time, but that's old news now. What is ICG imaging? A very small amount of reflective dye, Indocyanine Green, is injected just underneath the surface of the skin, intradermal. Using a PDE camera, the image is reflected to a screen, and the images are similar to a moving X-ray. A normal anatomy, the dye gets absorbed by the lymphatics and is taken into the system to drain. We see the normal route that the lymph will take when it leaves the microcirculation and drains back. Where there are abnormalities, we see congestion or redirection of the lymphatic drainage. We can see the valves of the lymphangions and if they are functioning and continent. With this information, we can diagnose, confirm, or exclude lymphoedema, some of its types and causes. We can instruct on treatment and improvement of care and, of course, specific manual lymphatic drainage pathways for individuals. How does it help patients? What we now understand is that our bodies choose the route which the lymph drains, usually the most direct, and with that, we have little choice to manipulate that route. Now that thousands of people living with lymphoedema have been mapped, we have a better understanding of where the most common routes may be. However, we've also discovered alternative and interesting routes and ways the body copes that we would never have expected. This has allowed for us to recommend bespoke drainage programs for manual lymphatic drainage and treatment plans. Some of these examples are the Belgrado pathway, where we see the drainage of lymph from one foot will drain up and drain across the abdomen and down the opposite leg. We also see drainage routes, pathways from the foot that exit at the hip region, deep at the trochanter region. We have identified that the smaller lymphoedema leg can be filling the larger leg, and we have identified that some breast edema is caused due to the failure of the arm and filling the breast, but sometimes the arm does not fill the breast and it is caused due to, for example, radiotherapy scarring. We've also been able to identify the presence of edema where people have been informed it is not present by others. This gives reassurance to the person who has the lymphoedema when they have been previously misinformed or that their body felt to them like it did have an edema. We've given reassurance that lymphoedema is not present, and someone may have been wearing a garment for years that they did not need and were misdiagnosed. We've been able to provide more accurate diagnosis instead of a generic primary lymphoedema. We have informed on insurance claims for clients for ongoing support and treatment. We've been able to advise people undergoing surgery of which lymph nodes or pathways to avoid, if possible, which can assist in the improved outcomes following surgery. We've been fortunate in surgeons accepting this advice and trying to work with solutions wherever possible. We also provide ICG imaging pre-surgical for people undergoing liposuction for lipedema, and this is often a prerequisite for surgery, particularly those travelling abroad for liposuction. Our extensive knowledge has allowed for us to support people with unusual diagnosis and unusual presentations of lymphedema or sensations of swelling. At LymphVision, our expert team also go above and beyond with differential diagnosis, which is outside of lymphedema, lipedema, or vascular abnormalities. This supports changes with treatment and increase of confidence in diagnosis. For some, we continue to hit brick walls in trying to secure that diagnosis with medical teams and referral onto the correct departments. Our extensive work has allowed for us to publish new lymphatic pathways. It has allowed for us to change myths and concepts of manual lymphatic drainage, the main one being not to waste any more life carrying out lymphatic drainage that is not necessary to areas that are fully functioning. Our publication of the LTA Compendium of Best Practice includes some of our studies. The drainage pathways published here, and with further words from other teams such as Macquarie University in Australia, demonstrate that there is no need to drain the leg to an axilla, unless you're the 3% who drain there. And presuming that most of the lymphedema population fit into the 97% who don't drain their foot to their axilla, it gives time and it alters self-management. Some of the information gained is not rocket science. We've been able to understand that if we empty lymph nodes, we need to empty them well. At LTA, we do this with the use of a soft ball in the axilla or groin or other nodal areas in order to ensure that the lymph nodes are emptied appropriately. We also understand that the more frequently the nodes are emptied, the more the lymph has the ability to drain into them and allow forward drainage. ICG imaging has allowed for the investigation into products, including electrostimulant devices and effects of compression. You will have noted the changes in garments over the last decade since understanding what happens with compression on dermal rerouting and how top bands can cause obstruction. With the above cascaded into training, change is happening and treatment and care are improving. ICG imaging has not only opened my eyes, it's opened those of patients who, when they see where their lymphatics are blocked or obstructed or where they're draining to, they can change this in their own self-management accordingly, and this can be life-changing for lifestyle and saves time. What hasn't happened over the last 10 years is the uptake of ICG imaging on a larger scale. Although there are many benefits to it, it isn't seen as a priority and therefore it still sits under private care. Unfortunately, that means it's out of reach for many. But on that note, I'd like to say that those who do have further investigation receive time back for their lives from understanding their diagnosis and how to manage it better. So my job will be done when I see ICG imaging paid for to the NHS. In summary, I would never change this process. It allows for so many advantages which have taken place to not only the individual's lives, but added to the bigger picture of training healthcare professionals with open eyes. And that has a cascade effect into other patient care. And for that, every single hurdle has been worth its weight in gold.